Well, hello and welcome. Thank you for coming today. We appreciate it. And my name is Kim Falone. I'm the clinical director of the practice. I'm going to introduce you to Dr. Lindahl, actually. So he's seeing patients in the office today. So this is kind of the agenda. I'm just going to go over the basic anatomy and then an overview of the surgery. And then we'll talk about options, manual surgery versus laser surgery, and then lens options. There's 3 different categories of lenses that we use, and I'm going to talk about them. And then we'll talk about some tools and diagnostics that we use. And then we'll briefly at the end, if we have time, just touch on glaucoma because it's becoming a big trend with cataract surgery. So Dr. Lindahl's our main surgeon. He's the owner of the practice. And then we have 2 ODs. An OD is an eye doctor that doesn't do surgery, but they do everything in the office. They're wonderful. They've been with us for years. And then our COO is Andrea. So I'm Kim, I'm the director. And then Kristen, we have 3 RNs, which is not normal for an ophthalmology practice. Dr. Lindahl finds it very important to actually have professional RNs on staff so that we're doing the best practices for all of our patients. So this is just a picture of the eye so that you can get familiar with the anatomy and just discussing what a cataract is. So basically, a cataract develops when proteins in your eye kind of clump together, okay? And it prevents the normal movement of light into your eye, therefore distorting your vision. So basically your lens looks like an M&M. Okay, there's a shell of your lens, your natural lens, and then inside when we're young, there's clear material. As we age, the material clumps up and causes cloudiness, okay? And then that's why you'll be going to the eye doctor and you'll get glasses and you'll say, these glasses stink, they don't work. Well, it's because you have a cataract and eventually glasses won't even work anymore. So that's when you know, okay, it's time for cataract surgery. That's one of the ways. There's different types of cataracts and different grades. So that's one of the things we look at when you come in. Go to the next one. So this is a good example of someone that's very advanced, okay? So he had cataract surgery in the left eye, so you can see it's just a black pupil. In the other eye, there's a milky white cataract. That's too long to wait. That's what we used to do in the old ages. We used to wait until a cataract ripened, they would say, but there was no benefit of doing that. So the new thinking is now, let's get it when it starts affecting your life. So if an eye doctor says to you, you have a cataract in that eye, then the next question is going to be, is it affecting your life, your daily living? Are you not driving at night because you can't see as well? Are you seeing glare? Our number 1 complaint is glare around headlights at night. So then it distorts your vision and you can't see well. Or just overall blurriness, and we'll go into more symptoms later on in the presentation. Okay, so historically, like I said, that was the old way of thinking. They would let them get this bad. This is actually a lens that they just pulled out of the eye. We don't do that anymore, but in the old days, that's how you removed a cataract. You made a huge incision and you just pulled it out. Now it's through tiny, tiny little incisions, and we break it all up, and it's with an ultrasound handpiece, and there's not this anymore. But I just wanted to show you this to show you what an advanced cataract looks like. And then, like I said, it's like the size and of an M&M, and it has the shell, and we leave the shell of the M&M. We leave it. We just take out what's inside because that's what's going to support your new lens, okay? And then this is a clear lens, and this is a clouded one, okay? And you can go to the next one. Okay, so these are the symptoms I was telling you about. This is when we would be ready for cataract surgery. So basically, your vision could be clouded or blurred overall. You may see those halos or glare or even starburst around the headlights. You'll have difficulty driving at night. The colors will be fading or yellow. And your glasses just aren't working anymore. Like, we'll bring people back, they'll call and say, these glasses I just bought don't work. We'll bring them back 2 to 3 times, and we're like, this is because of the cataract. We can't get it right anymore. Eventually it blocks, so you just can't see no matter what we do. Okay, a lot of people don't even realize they're having some of these symptoms, and after surgery, they're like, oh my gosh, this is like a new world. A lot of people see better than they've seen since 4th grade. So it's amazing, the results. The next one. So there's 2 ways of performing the procedure, okay? So I've been in ophthalmology. I started at Genesee Hospital 23 years ago. And it's so crazy how far the technology has come since then even. But what we've been doing, this manual surgery, since then, it's come a long way, but this kind of concept that that Dr. Lindahl just goes in your eye and he manually makes the incisions, and you'll see it on some of the videos in the future. And he uses this ultrasound handpiece. It's called a phaco handpiece, this little machine that's coming in. And he breaks the cataract into 4 quadrants. Then he uses this machine to break the 4 quadrants and take them out, okay? So that's manual. He does a good job. It's still a good surgery. A lot of doctors only do manual. It's not a bad surgery if that's the only thing you can get. But about 7 years ago, they came out with this laser called the LensX laser. And the laser basically assists the doctor with cataract surgery, okay? So before you even go into the operating room, you go into a room and you're sitting underneath a laser, and the laser does 4 things. It fixes an astigmatism, part of an astigmatism, depending on how bad it is. It breaks up the cataract. So do you see how he was manually breaking it? This machine breaks it into hundreds of little fragments so that then when he goes in with that ultrasound, it's like nothing to get it out, okay? And that's a benefit because sometimes when it's hard to get out, he uses a lot of energy in the eye, and energy causes inflammation and longer heal time. So breaking it up makes it so it's easier to get out, leading to less complication, risk, and just less inflammation overall. Then it makes all the incisions. There's 2 incisions that go on the outside of the eye so that he can get the 2 instruments in. And then there's an incision on top of that M&M that I told you about. It's called the CAPSULORHEXIS incision, and it's probably the most important part of the surgery because it's a little circle, and there's a slide on this later, that he has to make on top of that M&M so that he can get in and take all that material out. But that circle has to be perfectly sized so that the new lens sits on it and is centered perfectly. So when he does it, he does a great job. I've witnessed it happening hundreds and thousands of times. But the laser's more precise. He doesn't want to admit that, but the laser is more precise, okay? So I went over break up the lens, astigmatism, incisions, CAPSULORHEXIS. So that's what the laser does. So basically that's like a 5-minute procedure. You don't even have to be sedated for it. And after that, you go into the OR and finish up the procedure, okay? So this is that incision that I told you about. And it's funny because when the laser came out, the biggest benefit was that it fixed an astigmatism. But now that we've been using it and more studies have been done, the latest studies are actually saying, yeah, that's great, it does the astigmatism, but it's even better that it does this incision perfectly. So that's just some of the new data out. But if you can see, when he makes it with a little instrument, and he tries to get it perfect every time, but the laser is obviously more precise, okay? Okay. And this is kind of like just the steps through the surgery center. You go to pre-op, they dilate your eye, they take your blood pressure, anesthesia comes and talks to you. They get you all ready. You don't even have to take your clothes off. You just put a gown over your clothes now. You're on a stretcher that lays you down, and then Dr. Lindahl will stop and say hello, or he'll meet you in the OR. Or first, if you get the laser, you'll go to the LensX laser room. Then you'll go to the operating room. You're there for about 15 to 20 minutes. He's very efficient, very good at what he does. And then after that, you're going to go to the recovery room. So basically you're at the surgery center, we say, for 2 hours. Sometimes it's even less, but we tell you worst scenario just in case. But the actual procedure only takes about 20 minutes, okay? Do you guys have any questions so far? Yeah.
Is it local anesthesia or
Yes, good question. It is. She asked what the anesthesia was. So it's just like if you had a colonoscopy, they put an IV in, it's max sedation they call it, and they give you a little bit of Versed and fentanyl, usually that's the mixture they use. So you're awake because we want you to be awake because you have to like listen and say, oh, he might say look at the light or look up, look down, but you might not remember a thing. And be relaxed. And then we numb your eye so you don't have any pain, okay? And then by that night, you're gonna feel good. You'll be a little bit tired throughout the day. By the next day, you're gonna be feeling fine. Most people, well, a lot of people go back to work the next day, okay? You do need a ride to that post-op appointment because we do need to check your vision before we can clear you to drive.
how is it determined who gets the LASIX and
the laser? We'll get into that. We're going to get into that.
You said pre-op and then the lens?
Then the laser. So you'll start in pre-op, they'll get you ready. Then you'll go into the laser where they use that laser to break up that cataract and make those incisions, fix the astigmatism. Then usually you'll go directly to the OR after that. Sometimes they put you in pre-op for a couple minutes again, just to get the room ready, and then you'll go to the OR.
The OR is to insert the lens?
Yep, the OR is, so basically the laser he broke everything up, and now he needs to go take that material out and put the new lens in.
Is it like a vacuum or something?
Yeah, it's kind of like an ultrasonic. So it actually is, it's called BSS, which is a fluid that actually irrigates through the eye, and it's breaking up the cataract as it does that. So it's constantly replacing fluid in your eye and then taking out material. Yes?
How does it break up the lens but not affect the shell that you referred to?
That's his talent. So good timing. So this is Dr. Lindahl. And we'll stop now and kind of just have like a conversation. You can get to know Dr. Lindahl. I told him a little bit about you.
Have you gone through your slides?
Not the whole thing.
Well, why don't you finish up with...
You sure?
Yeah, because I've been sort of listening out there.
Okay, perfect.
Yeah.
All right. So actually, you can answer that question. How do you get the material and not the capsule when you're doing the surgery? Like, how do you take the material but leave that capsule in place?
Well, that's what we do for a living. So,
That's his talent.
You're very careful, and the likelihood of having the capsule disrupted would be maybe 1 in 700 to 1 in 1,000 cases. So it's fairly straightforward. Okay.
Okay, you can go to the next one.
But if it gets disrupted, can you still repair it?
Yeah. So you can still put in a lens, and sometimes you have to put it in a little different position. What's behind the lens is called the vitreous jelly, you may have heard of for biology, and those sometimes we'll have to take out a little of that vitreous, called a vitrectomy, before we put in the lens. Yeah.
That happens, yeah. Okay, you can go. Okay, so I'm just going to go, you can go to the next one. Go into, we're going to start talking about the lenses, okay? So there's multiple different companies, multiple different types of lenses, and I'm going to bring it down a little bit because if we go too much in detail, you're going to get confused. So we're going to consider it 3 categories of lenses, okay? So there's a monofocal lens, which we're going to talk about first. And a monofocal means it means distance. It's going to help you with distance vision. So just by taking out that cataract, you're going to see better because we're clearing up the vision. But putting the lens in is going to give you better distance vision. If you don't have an astigmatism, our goal is to decrease your dependency on glasses for distance, okay, with this lens. But you will definitely need help with reading and intermediate. Okay, so this is a lens that insurance covers, okay? Do you have any questions about, you can go to the next one, about the monofocal lens? But this is what we kind of look at before even discussing the lenses. We kind of look at what are your goals? Like, do you want to wear glasses less? Do you want to be out of readers? Are you okay with wearing readers, but you want better distance? So that is things that we're going to ask you, because that's going to help us determine what lens to put in, okay? What lens would be right for you. Okay. So this is the monofocal lens I was telling you about, and insurance covers it. And we're going to get into the next lens, which is, so this is, does everybody know what astigmatism is? Okay. So basically an astigmatism is when your eye is not shaped perfectly like a basketball, okay? It's more like a football, okay? So that's distorting the rays of light coming into your eye. And this is something we can fix during cataract surgery, okay? And there's a couple different ways to treat an astigmatism. The laser treats part of it, or sometimes all of it, depending on your degree of astigmatism. And then a lens that we use called a toric lens also fixes an astigmatism. And then there's something that we used to do frequently before the laser came out called an LRI. And it's basically a manual incision that Dr. Lindahl makes on your cornea to change the shape of your lens, of your eye, cornea. Okay, so this is the lens I was telling you about. We call it, it's called an Astigmatism Correcting IOL. We call it a toric lens, okay? And basically a monofocal, meaning one, toric lens will help you with distance. It will fix your distance. But if you have an astigmatism, it also fixes the astigmatism, making things more sharp and clear. Okay, so this is kind of the second level of lenses. There's monofocal, then there's toric. Okay, then the next level, insurance covers part of it, but most of it is out of pocket. And we'll get into that more at the end too. I could tell you about that. So I just wanted to kind of show you Dr. Lindahl's results. We did a study of 40 patients. And 40 patients, as you see, pre-op, had an astigmatism which was 0.76 all the way beyond 2 diopters, okay? And then he did the surgery and put in a toric lens. And out of those 40 patients, 36 of them had less than a half a diopter of astigmatism after the procedure, which is wonderful. Like, this is better than the national numbers for this kind of surgery. 3 of them had less than 0.75, and 1 person had less than 1. So amazing numbers, just to show you kind of he does a lot of work to do this, to get here.
What about the age? Does age determine?
No. Right?
Age independent.
Yeah. So just to show you a little bit, brag a little bit about Dr. Lindahl. Okay, so this is that third category, okay? We call this lens, so basically this is when you don't have that, you want that near vision, okay? So basically, as you know, as we're all aging, you eventually lose the ability to see up close because your lens loses that elasticity to accommodate. It can't accommodate anymore. So that's when you start needing those reading glasses. So this lens, which we call a multifocal lens, it could be an extended depth of focus lens or an accommodated lens. These lenses help decrease your need for glasses overall. So we can't ever guarantee that 100% of the time you wouldn't need glasses, but this lens is going to help you at distance. It can fix an astigmatism because it also comes in toric. It fixes intermediate, and it gives you functional near. Now, you're never going to see up here again because God just took that away from all of us, but it would be functional near, meaning like 16 to 18 inch, depending on which lens mix he put in, you would be reading down here. Now, it's not to say if you're in a dark restaurant and there's poor lighting, little menu, you might need some help. But our goal is at least, we try to aim for 80% of the time you'll be glasses free, okay? So that's what the multifocal lens is. These are just different companies that we use, Johnson & Johnson, Alcon, Bausch & Lomb, and different mix of lenses. Dr. Lindahl goes into, yes?
When you say multifocal, it's just kind of looking in bifocals?
It's different than that.
So you don't have to look.
No, It actually, there's a new lens that just came out, PanOptix, that is even better transitions than the other technology. But it's not like wearing a bifocal or trifocal. It's more just it transitions. You won't notice like the line or have to move your head a certain way to see.
Is it like a multifocal contact lens?
No, different. Same concept, right?
Same concept, but those are excellent questions because people will often say, you know, geez, I don't really tolerate progressive lenses in that well. This is the lens does all the work. You don't have to adjust your head. So if we get a patient to see well a distance with the lens, which is 20, I usually call that 20/20 to 20/25, then the lens is going to do what the lens will do. And what it'll do is it'll give you, when we call mid-distance is say a computer at say 24 inches or so, 22 to 24 inches. And what we call near is at 16 inches. So we usually measure where people like to read. So say you're a 5-foot patient or so, you're going to have a different reading distance than a 6'4" person, okay? And then we sort of show you what those lenses can do. But those distances, 24 and 16, will serve just about anybody, okay?
All right, so this is a lens that just came to the U.S. They've been implanting it since 2015 in Europe. It's their go-to lens in Europe. We, in the U.S., it takes a little longer to get technology just because it takes longer to get it approved by the FDA. So it just came. Dr. Lindahl was the first person to put it in Rochester. We've been seeing, do you want to talk about the results you've been seeing?
Yeah, this is an exciting lens for people that do want to reduce their spectacle dependence at both distance, mid and near. I can't tell you how many we've put in. Beth might have a little closer, but I would say at least 10 to 15.
I was going to say, yeah, at least. I was going to say 20.
Maybe 20 bilateral. So all of these lenses that are multifocal are meant to be put in both eyes. So they're not something you put in one because it's a new visual system for people. And we like to use the term for whatever reason, you know, my active seniors. So, you know, if you love to do a lot of things and garden and read and this, that, and the other thing, and you want to be less dependent on glasses, then this is a terrific lens, okay? The other thing we always look for is people who take their glasses off to read, which there's a lot of them. And especially if you're a woman and you take your glasses off to read, you also can put your makeup on without your glasses because that's a near task. So those patients, I always encourage them, if they've got otherwise healthy eyes, to consider using a multifocal lens because it's going to make them really happy, okay? So this lens I've used a lot of in the last few months, and you know, I'm really loving it. It's a wonderful lens, and like I say, the FDA here requires different things than their equivalent FDA, say in South America or Europe. So we haven't had it for a number of years, but it's been put in I think it's over 1 million people in Europe. So it's a well-studied lens. It's a beautiful lens. Yeah.
Is it a different technique or is it the same technique?
Taking the cataract out and putting in the lens, it's the same technique. So remember, when you're paying for something here out of pocket, you're paying for the technology, number one, and then a bit of extra work on our part to make sure we've got the lens that's appropriate for you. Okay. But it's not, and some people worry about, well, it's a different lens, it's harder to put in or take the cataract. That has nothing to do with it, Okay, you're really paying for the technology.
Some people, they don't have cataracts in both eyes. I mean, so they have cataract in one eye and they don't need the surgery in both eyes. So do you wait until that person, the other one gets?
We can do both of the eyes in a patient. If, let's say they want a multifocal lens and it's a binocular. Usually the eyes will, once you've done one eye, let's say you start nearsighted and we put in the lens to make you good at distance, which we're always going to do. There's an imbalance between the two eyes. So we can do the other eye even if it has very little cataract to bring it up. Okay, does that make sense?
No, yes.
So you don't have to have, in certain circumstances, you don't have to have a bad cataract to actually have us take it out. Okay. And again, that's fairly uncommon. It's not, most people have cataracts in both eyes. And once they have their worst...
They'll say, oh, it's not ready, they'll wait.
Yeah.
Sometimes
Yeah, we don't have to worry about that. There's nothing about ripeness anymore. Or anything.
Suppose a person who doesn't have cataract, like me, my cataracts are not, I don't need to have them removed at this point, but I would love to have this because I don't tolerate contacts.
Yeah, so we see a fair number of patients like you, and depending on, let's just say you're over 55.
Oh, yes. It's
Okay.
Okay.
I'm throwing it out there.
Generous, I'm well
Then-
over 55.
Some people will come to us in that age group for LASIK, okay? And once you get to about that age, I start thinking, well, is it better to do LASIK or is it better to do cataract surgery? If they got some early cataracts and we can demonstrate some glare disability, and we have a measurement to do that, then we can do those cataracts. And you get coverage for the cataract part of it, but you don't get coverage for the lenses. Does that make sense to you?
No, I understand it because what I understand that the insurance will only cover the
Monofocal. Yeah.
The mono.
That is correct.
So.
And then there's another group of patients of which some areas of the country do a lot of this. I've done some of it, but it's not common in this city, and that is clear lens extraction. In other words, in a 60-year-old with no cataracts and the ability, a lens out there that'll allow them to see distance and near, it's much better to do this than to do LASIK.
Right.
But you have to convince them, they have to know something, so they've been to a lecture or something. That's number one. And number two, if they have no cataract and it's not going to be covered, then they're also going to have to pick up the fee from the surgical center. So that gets more expensive. But I've done a number of those in people who either self-insured and they wanted these things done. So there's different possibilities. But typically now, the people that I do that for will have some mild cataracts. And so the cataract part is, at least the facility fee is covered and that sort of thing. Okay?
But then what about those people who you say they don't have the cataracts and then you do the lens surgery? Then what happens? Then what happens to them? Do they?
You're never going to get a cataract for sure.
I beg your pardon?
You're never going to get a cataract
because
you've already taken out.
That's what I was trying to have you say, that people, that's one thing that people wouldn't have to worry about then after the.
That is correct.
Because you didn't mention that part, so that's why.
It's a good observation. And it's sort of a philosophic issue as well, because if people want cataract surgery at a younger age and have it done, yes, there is out-of-pocket expense, but remember Medicare, if you look at what it costs, I mean, it's the third largest thing the government pays for, and cataract surgery is certainly one of the higher numbers, because there are about 3 million are done each year. I think they may even encourage people in the future to get them taken out at a younger age.
I was just going to say that because as we get older, then there could be more complications and other things as well.
Correct.
So that's why I was thinking that just seems like, it would make sense to do it at a younger age.
Yeah, no, those are good, very good.
But because as we get older, our eyes get drier, which was going to, I don't know if this comes in yet, because I do have dry eyes, and how does that affect the healing of these?
Yeah, so let's, we can talk, we always look for dry eye. We always work a patient up for dry eye, because that's part of the total workup for cataracts. And we define that before you're operated, how dry are you and what we're gonna do about it.
And we treat it before.
And we treat it, yeah.
If you truly
Yeah.
have it.
Is this a hard or soft lens?
These lenses inside the eye?
Yeah.
You mean,
So they're acrylic lenses and they're foldable. So that would be considered soft. They're a different material than if you're talking about contacts.
No, the
Okay.
intraocular.
The intraocular lenses, so they're made of either silicone, acrylic, a couple of other lenses, but most of the ones that I use, these are acrylic lenses.
Okay, but you fold these.
They're foldable.
Okay.
They'll go through about a 2.2.
So you don't use the
2.4.
hard lens anymore?
No, the PMMA lenses were the standard when I went into
Right,
ophthalmology. Beautiful lenses, wonderful
Last
material. But they don't fold. So the
Right.
smallest incisions we got those through were 5 millimeters.
Okay. Now,
And
do
now
these,
it's 2.4, right?
2.4, 2.2.
do these lenses change shape, or how do they change the focal point?
Well, they change the focal point in the same way any other lens system changes it. So we get our measurements at the workup that Kim's gone over, and then we choose a lens based on the size of your eye, the length of your eye, and the corneal curvature of the eye, that, those usually range between, I'd say, a 5 diopter lens and, say, a 30 diopter. That's the typical range for most eyes. And then we choose that lens that will bend the light rays appropriate to put it right on the retina, okay?
So this implant is not changing.
That is correct. No, it is.
It retains the same shape.
That is correct.
And thickness.
And then the trifocality and the multifocality is from the little rings. It's a diffraction type of grading. And that gives you those other 2 focal points that give you the mid and near.
Okay.
But again, you have to have good distance, and then the lens is engineered to do what it's going to do.
So it's kind of like the old cameras, the cameras that they had for years, the cheapies that Kodak had for, that you just point and shoot.
Point and shoot.
And if it's,
Autofocus.
and it did a pretty decent
Yeah.
job.
Yeah, and you can see, can you see those little rings there? I can't from this.
So there's little
rings
rings all the
So-
way in there, yeah.
Oh, okay.
So you'll see those in there, and those give you those extra focal points.
So
You know.
does the astigmatism stay, if you treat, because people who have the astigmatism, does it ever?
You're treating astigmatism inside the eye instead of outside the eye like you have with glasses.
Right, so can the eye go back into that football?
The eye stays in the same shape. Okay, you're not changing the shape of the eye with cataract surgery. You're just putting in a lens that treats that inside the eye. Okay, you're not changing the shape of the eye.
Okay, now I'm getting what you're saying.
You're thinking about LASIK. LASIK changes the shape of the eye.
That's, okay, all right, thank you.
Yeah.
When you try to correct a mild astigmatism with the laser, does that change the shape of the eye
Yes, it does.
a little bit, or?
Yes, it does. That's exactly correct. Because that's at the surface. That's on the corneal surface. Okay.
And you say that's pretty successful?
And that's very successful. So I use that for typically lesser amounts of astigmatism, usually between 1/2 and say 1 to 1 1/4 units of astigmatism. And we really like the toric lenses are a super for over a diopter. Okay.
Okay, so this is just a little bit of bragging of, this was Dr. Lino putting in that first lens.
Those 2 handsome guys on the side, they're Alcon reps, and they were there to. So it's been a nice addition. It's a beautiful addition to our armamentarium.
All right, so I'm just going to tell you a little bit about our cataract process, which is pretty individualized in Rochester. We're the only one that does the process this way. We do it all in 1 visit, because most places, and what we used to do it in 2 visits, and we know how busy you are. We know that it's hard to get to doctor's appointments. So we combined everything we need into one visit. So the one visit is a long appointment. It's 1.5 to 2 hours. You would come into our office, which most of you saw. If you didn't see it, please stop in and see the office. It's beautiful. Just renovated two years ago. So you start with a specialized tech that does your basic eye exam, and then she does all the testing we need to do your cataract surgery. She's taking pictures of your eye. She's doing a test called an IOL master, and that's kind of what determines what lens strength that we're going to put in your eye after. And then after that, they're going to put you in a room, and either I or Beth are going to come in and talk to you. So we're going to give you the spiel that we kind of just gave you in more detail today. But this is what's going to happen during this appointment. Dr. Lindahl's going to come in. He's going to take a look at your eyes and determine what you're a good candidate for. We're going to look at your health history, what meds you're on. We're going to look at what your lifestyle is like, and what your hobbies are, if you're retired, if you're working, because all of these things go into how we determine what would be the right lens for you, okay? So then after we meet for about 10-15 minutes, Dr. Lindahl then comes in and actually looks at all the testing you just had, and then he takes a look at your eyes. After that, he tells you what he thinks that you should get based on all of that information, and then Beth and I go into an office with you and let you decide what your options are. Okay, so that's kind of the whole appointment. And then at that appointment, we also schedule all your appointments, which would be 2 surgeries, usually about a month apart. And then we see you the day, because we do one eye at a time, if everybody didn't know that. We do one eye, and then about 2 weeks later, we do your second eye. So then we see you the day after each eye. We see you a week after your first eye to get you ready for your second eye. And then we see you, or your regular eye doctor sees you 3 weeks later. Okay, so we make all those appointments for you at that visit. Usually we're scheduling in about a month. That's our typical, like you see us and then about a month later you have surgery. But it doesn't have to be like that. All of those tests are good for a year, right? So if you come in and have all the testing, as long as you have the surgery within a year, we wouldn't have to bring you back again.
After you're presented with your options, do you have to make a decision on the spot, or can you go home and think about it?
Some people go home and think about it. It's up to you. So we basically say, if you want to finish the appointment today so that you don't have to come back again, you can make your decision today. If you don't mind coming back again, because we have to do the consents and it has to be specific, and the financials and everything has to be specific to the lens. So if you couldn't make a decision that day, absolutely you can wait and come back again.
What percentage of our patients do not book on the day?
I would say 5%.
5%.
If that even. Yeah, some people just want to go talk to their relatives and decide and look at their financials, and that's totally fine.
Yeah.
I just wanted to know, is this everything the same, and is it still as successful for people with diabetes? Are there any long-term risks?
We pay close attention to diabetes. That's an excellent question. If someone has diabetes, but there's no changes in the back of their eye, there's no diabetic, what we call retinopathy, then the risks are the same as a non-diabetic. If they have some swelling in the back of the eye that's due to diabetes, then there are a couple of additional risks. Most of them have to do with swelling after the surgery, and we actually treat them a little different with drops afterwards. If they have a retina doctor, the retina doctors often will treat either a couple weeks before cataract surgery or a couple weeks after to try to avoid any issues. But same risk if you don't have any changes in the back of your eye.
I did want to ask you a question before you left as well. My sister had the cataract surgery, and then she had to go back and have it tweaked. How
Was that a laser
was
afterwards?
This was back 2012, so I don't
It was probably a yes.
The most common thing we have to do, which is very common post-op, perfect. Within, let's say, 1 to 3 or 4 years, is a laser to tidy up. Remember, Kim talked about the capsule, that we leave the capsule. Well, the back part of that capsule, your own cells can sort of grow over it, and it causes sort of a haze. So it'll be like looking through a dirty windshield. And we clear that up with a simple laser. So that's the most likely thing that needs to be done afterwards.
Yeah, because she had trouble with her vision, and then she had, well, you could.
Yeah, and then I went within probably weeks to have it done.
There's an occasional patient, did you have to have a different lens put in?
No, I don't even know.
We rarely would have to explant a lens and put in another one. That would be very rare, but that can happen. And that's a simple procedure, but you got to go through it again.
Yeah.
You can take the old lens out, put a new one in.
All right, well,
Nice
thank
seeing
you,
you.
Dr.
Yeah,
Lindahl.
nice to see
Okay, so this is kind of some of the education that Beth and I would go over before the surgery. And I gave you all a copy of the lens options. Beth, could you grab me one of those lens option sheets? If you guys want to look at that sheet, I'll kind of talk you through it. So there's different steps of what you can get. And it really depends on your eye health, what other problems you have, what you would be a good candidate for. So some people can't get the laser because they have some corneal issues or there's something going on in the back of the eye. So basically that's what we're determining. But these are all the different things we offer. So the first category is just a standard cataract surgery. That's manual surgery, and that's putting in that monofocal lens, okay? So there's no...
Does it make sense to
Everybody, if you didn't get one, we could get you one. Oh. Yeah, to visualize it. Sorry. So basically, if you can read that, you're doing well and you don't need to be here. I can't even read that.
Always here for you.
Yeah.
I was here this morning, so.
That's so funny. So basically, this first category is going to help you with distance vision. Okay, so the monofocal lens helps with distance. The only out-of-pocket expense you would have here is whatever your copay or deductible would be. So you can look at your insurance card today and call your insurance company and say, I'm having cataract surgery at Brighton Surgery Center. Could you tell me what my copay will be when I go there? And they'll tell you exactly what it's going to be. So that's the only out-of-pocket for the monofocal. The second column is the toric lens, the Astigmatism Correcting Cataract Surgery. So this category is going to help you with the distance vision, but it's also going to fix your astigmatism if you have one. Okay, so that one, out-of-pocket cost are $2,300 around, and that includes the laser as well. That includes all of our fees and then all of the surgery center's fees. So basically, in order to use the laser, you have to pay them because insurance doesn't cover it. And then for the actual lens, you have to pay for the lens. And then part of it is Dr. Lindahl's professional fee. So for all of these options, we know it's a lot of money. Who has this much money in the bank that they can just throw to surgery? So we offer 0% interest financing for 2 years, okay? So then the third column is the advanced technology lens, and that's the multifocal lens that we talked about that's going to help you with near, intermediate, distance, and astigmatism. And that one is around $3,100. And that one, it tells you what the monthly payment would be per eye too. And then the only other option, say you were getting the monofocal lens, but he wanted to fix a small astigmatism with the laser, that's the next column. So basically, the laser alone with a monofocal lens cost about $1,200 per eye. And then the last column is one of the treatments that we do for dry eye. If you come in, we would do and you have really bad dry eye, we would do a dry eye workup. So the dry eye workup, basically there's different reasons why people have dry eye, okay? So sometimes there's glands underneath your lid that are straight glands and they secrete oil. So as we age, mine are already going away, everybody over 40 years old basically has dry eye, they start disappearing. So then your eye is not producing that oil layer. So what happens is because there's two layers, there's an oil layer, then there's a fluid layer, it dissipates. The oil prevents it from dissipating. So if those glands aren't working well, this is what you do to clean out the glands. Because basically what happens is your glands get goopy and they're not draining and then they die. So this is like a spa treatment. I had it done in front of a whole crowd because we had a conference and I was the guinea pig. And it was great. I have to admit, I was very scared because I don't like anybody touching my eyes. But it just goes in your eye and it's like a massage and it massages those glands open, and that is what LipiFlow is.
But if the cells die, what cells?
The glands, actually. So once, say you have like 25 glands that go across your eye, if they die, they never come back. So we're not trying to get them back. We're trying to preserve what you have. Because once you lose it, it's gone forever. So if you see people with really irritated looking eyes, it's because they probably don't have any glands left. So you want to preserve what you have. But that's a whole nother seminar. Huh?
How long does this treatment take?
That treatment takes 12 minutes. You're in a room for about 20.
How long, so
So
longitudinally?
we try to make it last 2 to 3 years. And that's up to you. You can make it last longer by doing the right things in between, which would be artificial tears 4 times a day, like high quality artificial tears. And then compresses. So we actually sell the mask, so you can do warm or cold compresses, whichever you needed, twice a day at least, we say. And then we encourage people to use flaxseed or extra virgin olive oil within your cooking, or omega-3 oils. That will help keep things good too. So that makes the LipiFlow treatment last longer, keeps those glands cleaned out.
Suppose it's for someone who has like Sjogren's.
It would be the same. Yeah, it would be the same because you're more apt to have dry eye. Mm-hmm. Now, what we would need to do, though, is let's determine, we need to take a picture of that lid. We literally use this little machine that flips your eye lid. It doesn't hurt. It takes 2 seconds, no big deal. And we take a picture of your glands and show you, and it shows you exactly. So we would look at that, and then we would look at your tear osmolarity, which we would see, and then we do one other test, and it tells us, is this a fluid issue, not producing the fluid? Is this a gland issue? What kind of issue is this? And then there's all different treatments for after we determine what your problem is. Mm-hmm.
How come this is a nursing procedure and not a physician?
The LipiFlow? Yeah. It's not, like, it's truly, no, the physician determines what you need and then we actually do the treatment, but it's very simple. It's not like a surgical procedure. It's literally like a spa treatment. You're laying down in a chair and we just put 2 applicators in your eye and it just massages those glands. No, we don't need Dr. Lindahl to do it, that's for sure.
Who does the diagnosis of what?
The
type
doctor.
of-
The
so
doctor.
you see the doctor first?
Oh, of course. Yep. He orders what you need and then we do the procedure.
Now, is that covered under insurance?
No. Now, some treatment for dry eye is covered. Like say you needed eye drops. Sometimes, depending on your insurance company, they do cover the eye drops, but they don't cover LipiFlow. Unfortunately.
When you do this, are you like putting on a pair of goggles?
Nope, it's just like a little plastic piece that sits on your eye, but it doesn't hurt, it's soft. And literally it just massages your glands. I wish I could have showed you a picture of it. Yeah, it's on the website. And you can even Google it, LipiFlow, and you'll be able to see like examples of it.
Is it like a contact lens sort of plastic?
It's not like a contact lens, it's like a white, opacified white, but it is kind of the same concept, like it's just a soft lens that goes on top of your eye. And that's just to protect your cornea. The real work is on the edges. Mm-hmm. It's pretty cool, I've had it done.
Is it connected to electricity? Is there electricity?
It's a machine that massages. So it's connected to a machine that actually goes through all these pulsating. You'll feel it getting warm. It's really relaxing, actually.
What's the
I bet it
fee?
feels good.
It's $600. For that, we offer, if you're only getting that, we offer 1 year, 0% interest financing. So it comes out to be $50, which is great. When it first came out, they charged us so much for the applicators that most people couldn't afford it. So it just came down like the last year, about $400. So it's good. It's at least more affordable than it used to be now for patients. But yeah, dry eye is a whole nother seminar. I never even knew about dry eye until I started working here. People are not educated about it, and it really affects your vision. So, yeah, so Dr. Lindahl is a huge, like a lot of people who go to eye doctors for years and then come here for a CAT consult, and they obviously have had dry eyes for years and they were never treated. And we're like, first thing we say is forget the cataracts right now, let's figure out this dry eye. So yeah, just make sure you're going to a good doctor that's actually into dry eye, because a lot of doctors aren't. I don't know why, but you just make sure they're doing the correct test and that you're getting a good dry eye workup. Some signs of dry eye, if you don't know, are fluctuating vision throughout the day. If you have a cataract and it's affecting your vision, that's going to be all day. It's not going to change throughout the day. If you have dry eye and like one part of the day you're blurry and then later it will come back, that's dry eye.
And also there's pain too.
Yeah, pain, irritation. Yes, we actually started, we went to this big seminar and they focused on dry eye, and we learned about these new wipes, because part of dry eye could also be bacteria that forms on your lashes, and it clogs things up. So, and causes things to happen that cause dry eye. So if you saw the pictures of it, you'd be like, oh my God. It's like little mites.
I think that mites are.
It's like that. That's what they look
Yeah,
like.
there was some controversy on it.
Yeah, I don't know if it's actually a mite, but it looked pretty gross to me. So, under the microscope. But we sell these wipes in the office now that actually, they're tea tree wipes, which kills that. I don't even know if it's a bacteria or what is it. I don't even know what those little things are, but whatever they are, we want them dead. So yeah, these are only sold in ophthalmology offices, and they're truly made just for this, and they're great. We're all addicted to them because they also help with wrinkles and skin moisturizer. So you do your eyes, and then you go around your whole face. I do my whole body with that little wipe. But they're like around $20, but they last for a long time. There's 60 of them. They say to use one for each eye. Don't do that. Use one, do your eye, flip it over, use the other, and then do the rest of you. So, yeah. So they last 2 months, and they're about $20. I even have my kids using them because they also help with acne. So, it's like a miracle drug. Yeah. 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 So then we also sell that mask that I was telling you about. You can put it in a microwave, 15 seconds. The nice thing about the one we have is most of them get gross because you use them every day and you can't wash them. These have a cover, so you can take it off and throw it in the wash. And then we sell really good artificial tears that right now we have a backup to what we sell, but the ones we have now are good too. The ones we usually sell are called Oasis. They're on back order because they're so great that they can't keep up production. And they're just very lubricating, and people find that they have to use less throughout the day than the normal Restasis or Sustain. So we started selling them in the office also. Also because people would be confused when we said, go get artificial tears, and they would see that wall of tears at Walmart. So we thought it's just easier if we sell them, then they know they're getting the right ones. And they're preservative-free, and it's a multi-dose vial, so that you don't have to carry around all those separate tubes. And it's better to get preservative-free because it's less irritating on your eye.
Do you have any patients on plasma tears?
Actually, yes, we just started doing that. So there's a new thing that it's like final treatment, like if nothing else works for a patient, you can draw a patient's blood and they actually spin it down and take the plasma out, and they make a tear out of your own plasma. So we just started doing that. We send our patients to Strong because they're the only ones that do it here. And
Actually, I'm so sensitive to all eye drops.
Yeah.
And I love the plastic.
really, well, it's your own, well, yeah, you shouldn't react to it. That's what we've been hearing. So yeah, we have been doing that. That's final resort, just because it's a little inconvenient.
Yeah, and unfortunately, my insurance covers it, but I don't.
Yeah.
I get
Yeah.
other people I know and move on to other things.
Yeah. So basically that's kind of it. And so most places or some places in the country hire salespeople to be in my position or best position. So Dr. Lindahl is the opposite of that. So we don't sell, we educate you on what all the options are, and then you make the choice of what you want, okay? So we're not pushing this advanced technology. If we didn't offer it, it would be a disservice to you, because then you would go back to your friend, like having lunch, and they would say, I got this lens and I don't even need glasses for this menu. And they would come back and say, why didn't I get that lens? So we offer everything to every patient, but we do not push it. It's ultimately your decision on what way you want to go. It's all based on your goals, okay? Some patients we really force to do things because, like, I had a patient that had, like, what was it, like a four diopter astigmatism, which is the worst, like one of the worst we've ever seen, 4 or 5. And he was like, no, I just want the monofocal lens. I'm like, no, you are getting this lens. Like, I'm not letting you out of my office, because he had Parkinson's disease and was already falling, and then also had terrible vision. He was like a -10. So I'm like, no, you're getting this lens. And I finally talked him into it, and he literally came back with gifts for us. And he's like, I have never seen this like this ever, my whole life. So some people we do force, but if it's, yes, actually I wasn't gentle on that one. I brought his son in, and I'm like, this needs to happen. So you guys have to figure it out, because it really needs to happen. It's going to change his life. But just so you know that, we don't want you to ever think we're pushing.